what is veterinary physio? It's the same, but very different as human physiotherapy. So it's the same techniques, but obviously slightly different individuals that I'm doing it on, and some slightly different biomechanics, as you will all know. The big thing about veterinary physio versus human physio is that physiotherapist, physical therapist is a protected title by law, whereas as soon as you put animal or veterinary in front of the term physiotherapist, there's no protection of title whatsoever. So because of that, there are multiple associations at varying levels of qualification, varying levels of courses. You can literally get a vet physio course on Groupon. I do go home and cry about this on a regular basis. I, however, have done a master's degree, and if you get an ACPAT physio, then you are guaranteed that you have got a chartered physiotherapist, so someone that has been trained as a human physiotherapist and then has gone on to do a master's level degree in veterinary physiotherapy. That's why I bang on about ACPAT physios. Anyway, right, carry on. Actual physio, what are we going to talk about? So I'm just basically going to reel off a load of problems, diagnoses that we can actually help with, some of which you'll probably go, yeah, of course, and some you might hopefully find a little bit surprising. And then the next time you get a patient coming up with one of these, maybe you can think, okay, we can add physio to the complement as well. So orthopedic wise, we have joint dysplasias, and in hand with that, we've got osteoarthritis. So obviously beginning of the journey, end of the journey. There's lots we can do to help before, from an educational point of view, to the carers, but also to the animals themselves. Yes, I can't change the bones of a joint, but we've got good research to show that if you can make the muscles that surround a joint stronger, you can significantly reduce symptoms within that individual. So that's obviously from human research, but they can actually tell us that the pain goes away in that joint if we just make them stronger. That's not adding drugs, changing drugs, that's not doing surgeries, that's literally just making the muscles stronger. So we can do stuff to help from a physio point of view in your joint dysplasias, your osteoarthritis, even if you're at I'm not saying please do give them drugs. I'm not saying don't give them drugs. I'm not saying I fix everything. I really don't. And we should be part of a multimodal team, but physio can be massively useful in these cases. We've also got obviously the more obvious ones of the post-operative rehab, so your post-op TPLOs, MPLs, NAMA, surgery, orthopedic surgery, any surgery. And yes, I do think that we should be doing physio post-operatively. You don't give a human a total hip replacement without giving them 1 day post-op physiotherapy. On that note, when do we start physiotherapy? 1 day post-op, please, please, please. Don't wait until 6 weeks. It's far too late at 6 weeks post-op. Don't even wait till 2 weeks. It's too late. ASAP. I appreciate you're not necessarily going to be able to get to me at 1 day post-op, but the sooner you refer, the better. Please don't leave them on cage rest for 6 weeks, atrophying their muscles even further. So I've got even further to work from to get back to. There's stuff I can do that's low level, we can do that's low level, that's not going to affect them from an orthopedic standpoint, surgical standpoint, from 1 day post-op while they're still on cage rest, that can delay or reduce the level of muscle atrophy that you're inevitably going to get from reduced exercise. What else? Muscle strains and your unexplained lamenesses. So absolutely got no problem. Please do give them their 7 days of meloxicam and tell them to rest. But if they come back in 7 days, maybe think about me, because that's when I can absolutely help. Because yeah, we all have aches and pains, and we all wait, and we go to our own GP and they give you ibuprofen and tell you to go away for 7 days. But when you come back, then that's still a problem. Something needs to be done about that at that point in time. And maybe you don't need to go down the incredibly expensive orthopedic surgery, orthopedic investigations, x-rays, etc., because it could be a muscle strain. It could be the beginning of a tendinopathy. It could be something really minor, but something that a physio can fix. And we can make them better or help them in a way that, and you know, certainly if you're referring to the Ralph, and most ACPAT physios I know, if we're assessing a patient and we go, whoa, no, this is orthopedic, we're going to send them back to you, or we're going to send them on to an orthopedic surgeon. We're not going to try and treat for the sake of treating, because that wouldn't be helpful for us apart from anything else. It's certainly not helpful for that patient or that carer. So yeah, please feel free, if they come back after 7 days, please come and think maybe physiotherapy is the next step in that chain. So yeah, muscle strains, unexplained lamenesses. So unexplained lamenesses, sometimes that is, as I said, your 7 days of rest, but also sometimes that's they've had the orthopedic referral and they've found nothing. They've had the neuro referral and they found nothing. Then maybe think about us if they haven't had physio already, because this is what my orthopods and my neurologists do on a regular basis, because there are things that you guys are not taught to look for. I mean, I don't know why the SIJ doesn't exist in a dog, because believe me, it really, really does, and it can be dysfunctional. And yes, physio can help with that. There's all sorts of stuff, and this is why another reason I like ACPAT physios is because I have spent 10 years in the NHS learning on a mammal that goes, ouch, and if you poke that, it gives me a burning pain down my leg and things like this. So I can equate my palpatory skills and some of the problems that we maybe don't think of in veterinary terms, I can see and I've treated in my dogs and cats, and yes, they have gotten better, because I don't think that these aren't problems that don't exist in animals. I think they just can't tell us about them, and we haven't yet got the ability to, if they've got an SIJ problem, an SIJ dysfunction, you can scan them and MRI them, CT them, X-ray them. You will probably never see any abnormalities, or if you do, you don't know if they're just consequential. The research in humans with SIJ dysfunction shows that there is no correlation radiographically, pretty much, between their signs and symptoms and the radiographic findings, because the SIJ is so convoluted. So it's always worth a try for physio. And again, we're not going to spend time wasting both my time and the carer's money and the patient's time if we don't think we can help. So even if it might be a one-off assessment, you can at least go, okay, that's one thing ticked off. There's nothing from a physiotherapy point of view. TMJ dysfunction. Yes, I do play with TMJs. Very carefully. Usually under sedation, because I kind of like to keep my fingers, and they're quite important to my job. But there have been a number of dogs. I've not done TMJ in a cat. I'm not sure I'm that brave, even if they are asleep. But yes, I've helped with TMJ dysfunction a fair few times actually while I've been at the Ralph, in conjunction with our dentistry team, but also in conjunction with neurologists, so some scar tissue post masticatory myositis, things like that, but there are things that we can do to treat your TMJ. Cool, I think let's go to the next. Prehab. So if you've got an animal that for whatever reason cannot, if they have a problem, yes, it needs to be fixed, you know, it probably will need surgery, but maybe for insurance reasons, but it's still ethical to delay a surgery, but because the insurance hasn't renewed, the patient is not going to suffer overly. Because of it, get them into prehab, because if we, as I said, if we strengthen a joint, we can make it feel better, we can help, and also then their post-op recovery is going to be 1,000 times better and quicker than it would be if they hadn't had the prehab and they'd had another 6 weeks or however long it is of sitting around doing nothing because they're not able to move, so they've got that much more muscle atrophy. That also goes for if in an ideal world they should have surgery, but maybe they're too old or too unwell, they can't, physio. We're not going to fix it, but we can make it better. Neurological. So post-op hemilaminectomy, intervertebral disc disease, whether that's so conservative, they kind of go hand in hand. And again, one day post-op, one day post-op, one day post-op. Please guys, sooner rather than later. When you're a physio at the Ralph, that's about 90% of your day, every day, is rehabbing the busy handiwork of our neurology department. And great fun it is too. But yeah, there's so much we can do, both from a conservative point of view, long-term management of these patients, and also from a post-operatively. We've got grade 5 dogs walking again. Yay, brilliant, so much fun. If you want to scroll down our Facebook, the Ralph Facebook page, there's a video of me waxing on about 2 French Bulldogs and 3 Dachshunds. Shocker, what a breed. Who knew those breeds would be the ones? Who were all grade 5 and all are running around like lunatics again now. Fibrocartilaginous embolism, can never say that, and polyradicular, and ANMPE, so acute non-compressive nucleus pulposus extrusion. The only treatment for them is physiotherapy. Get them to us. The sooner you can get them to us, the quicker we can get them back on their feet. And it's really important with the FCEs and the ANMPs to get to us as soon as possible, even more so probably, because they tend to have the most dramatic recovery within the first 2 weeks, week to 2 weeks. So if I can affect their movement programs at that point in time, when they are learning how to compensate, because they've usually got a monoparesis by this point in time, I don't want them at 3-4 weeks when they've already learnt to walk on 3 legs, basically. I want them as soon as possible so I can stop the bad habits before they start. DM, there's some great research out there that physio can prolong the life of DM by months. So when you're talking about a patient, a much beloved dog, months is a good thing in the life of a dog with DM. So yeah, we can do a lot to help. Hydrotherapy as well, and we've got Hydra at the Ralph, so yeah, we can do a lot. We've definitely had some DM dogs that we've prolonged their life. I mean, probably the best one we ever had, I reckon we probably prolonged their life by about 9 months. That's unusual. That's a lot more than normal, but we definitely can. We can add months to their life of decent quality of life, I would like to stress. Wobblers, lumbosacral disease, obviously again, less we can do because I can't do anything about the joints, but again, we can strengthen, we can help with coordination, movement patterns, we can help with secondary compensations. There's all sorts of things that we can do to improve quality of life, make moving less effortful. So yeah, and then some of the more unusual ones, tetanus. Yes, we do get involved with the tetanus. Post the acute stage, there's lots of stuff that physio can do to help tetanus. We've got a patient that we're treating at the moment that had some really severe tetanus. Vestibular disease, both central and peripheral. There is all sorts of stuff that we can bring from our human physio. There is this entire branch of human physiotherapy that is specifically to treat vestibular disease. There's all sorts of things we can do. I'm not saying that we're going to stop them from having a wonky head for the rest of their life, but I can definitely stop them from having a less wonky head for the rest of their lives. And also probably get them walking not in a big circle anymore. So yeah, there's lots we can do to help with both peripheral and central vestibular disease. Have I done? Oh, GULP is the last one. So geriatric onset laryngeal paralysis, polyneuropathy. God, there's too many letters, aren't there? Again, that is something that we can help with. It's the polyneuropathy bit of that. I'm not going to make them breathe better or cough less, but I'm a respiratory physio by my human history, so I can educate carers about how to prevent aspirations and pneumonias a bit more, and I can spend more time with them than maybe you guys have got, which is the other difference. Is I've got 45 minutes, half an hour to talk to these carers, as opposed to the 10-15 minutes that you guys probably get, if that. So I can help with the education from your point of view, but also the polyneuropathy. So it's usually within about 6 months of the laryngeal paralysis showing, you get signs of pelvic limb paresis, that's where we can come in and do some actual physio strengthening and stuff as well. Cool. Oh, and canine cognitive dysfunction. So I've added that in because in the human world, there's loads and loads of research that physiotherapy and exercise therapy specifically massively helps with patients with dementia. There's no, shockingly, because, you know, there's so much veterinary physiotherapy research. Oh, wait, no, there's not. Makes me sad. But there's no research in the canine world, but there is no reason why the physiology is very similar. There's no reason why it couldn't help as well. Also, there has actually just recently in the last couple of weeks been some research out there which might be worth any guys here that work in a practice that have got class 4 laser. You might be interested to look up because they're doing transcranial laser. So let's laser that brain, but which sounds pretty damn scary, but in actual fact, it has helped the symptoms of canine cognitive dysfunction. So it's worth looking up that paper. Respiratory, my favourite bit. I'm weird, I love phlegm. I know I'm odd, but hey. So essentially that little thing down the bottom that says sputum retention, if it's a problem that has sputum retention, I can help. There are both hands-on techniques that I can use. There are systematic sort of advice and things keeping your patient hydrated, and that's not like in an acute setting. You guys know how to do that, but it's also making sure that the carers are offering water, keeping their dog hydrated on a day-to-day basis. If you yourself, next time you get a chest infection and you're really you've got a hacking cough and you can't cough your phlegm up, I promise you, drink a litre of water, 20 minutes later, you'll be coughing that phlegm up. I know, I'm gross, I'm sorry, but I like phlegm, I'm just that person. So other stuff like that, education to the carer, but also manual techniques and also exercise. People are scared to exercise the respiratory compromised patients. Exercise is the most effective form of chest physiotherapy going. Now, when I say exercise, that's one level up from the level they can currently manage. If you have a recumbent patient, exercise is standing them up. If you have a patient that can stand up, exercise is making them walk around the room once. This is not a lot necessarily, but I guarantee you that if you do that, they will cough, because the second you exercise them, you increase their tidal volume, they have to take a deeper breath, that will mobilize the secretions, they will start coughing and clearing. It's a useful technique. Chronic bronchitis, so again, lots of education to the carer. I can help with clearance techniques. I can even teach the carer clearance techniques if we think that sputum retention is the problem within that dog. Recumbent patient, both preventative as well as curative from both a physical point of view and a respiratory point of view, preventing post-op pulmonary complications, etc. Yeah, the rest all comes hand in hand. Ventilated patient, that's my favourite thing because I get to play and I can actually suction. And then the geriatric patient, basically read all of the above I've just been speaking to you about. There's all sorts of stuff that we can help with, but that includes palliative care. Palliative care is not they're about to die any second. Palliative care is any uncurable disease. So osteoarthritis, I'd have anything like that. Chronic pain, degenerative joint disease, even just cardiovascular deconditioning. The other one that, I missed off the respiratory one, which I wanted to talk about, is the potential for cardiac rehab. Again, there's something that is not ever spoken about in dogs. There's no research as to cardiac rehab and dogs. However, the research in humans is that patients with congestive cardiac failure and other cardiac conditions, but congestive cardiac failure is probably the one that's most equivocable from a human to dog point of view. Physiotherapy can be more effective at controlling and improving the symptoms of CCF in humans than drug therapy. Now again, I'm not asking you to stop giving your dogs drugs. Please do, they need to have them. But they may not just be not moving as much and slowing down because they're getting older. It may be that we can treat them for this and help improve that. We also have, if you come to the Ralph or refer to us, we've also got a few other things. So we've got an underwater treadmill. We've got a 3B laser, which is similar to your class 4s. It's just slightly less powerful. You can do it, you basically use it for all the same sorts of things. We have a stance analyzer. If you've got a truly recumbent, heavily dependent recumbent patient, we have ceiling mounted hoists in both hydro and physio, so we can see the most debilitated patients and we can still attempt to do something with them if that's appropriate. And I myself make custom neoprene and thermoplastic braces. These below are two of my most challenging cases: a radial a carpal support after a collateral ligament had been surgically fixed. Daxon's leg was that big. And my orthopaedic surgeon was like, yeah, you can do that, can't you? And I'm like, can I? Okay. And then the mad Vizsla was an AA luxation that, yes, we didn't treat conservatively, but it took us a week to get the guides, etc., to do the surgery. And in that week, we had to stop him basically having his own head fall off because he liked to jump a lot. I mean, genuinely, we got called going, Kim, you might need to have a little look at the collar you've made, because he's just woken up from his sedation and he's jumped so high, he's managed to get his chin over the top of the walk-in dog kennel. I ran. I didn't hang around for that one. Yeah, so all sorts of weird and wonderful things. And the other handy thing that we have are wheelchairs. I don't use these as an end of the road, oh my God, there's nothing left to do. I use these like I'd give you guys a pair of crutches. They are a walking aid. They are an assistive device. Can't say that phrase either. We have them for full quads, so all full tetraparetic, tetraplegic. We also have them for just the rears. They are massively useful at getting patients back on their legs and walking in a correct movement pattern in a way that slings and harnesses cannot do. And we rent them out. We fit them, we rent them out, and if appropriate, we will also sell them. So we can do cart fitting and selling without the physio bit, if appropriate, etc. as well. I think, end of the day, I'd much rather you email us and go, would physio help with this? And me go, no, sorry. I don't very often say that, I have to say, but then you not ask and me go, I could have really helped with that and we could have helped that patient. Always ask. If I can give you advice that you can do yourself, brilliant, I will do that. But there's all sorts of stuff that physio can do, so please do ask.